So I was approached a couple months ago by the producers at Grey's Anatomy to provide my input on a spine case, an episode that they were about to film. The producers called me one day after work and we discussed some areas of spine and some questions that they had, that the actors as well had, before filming an episode about some spine case. So we had about an hour or hour and a half discussion over the phone. They asked me questions about certain procedures, and they asked my input about a particular episode. In this video today, I'm going to review that particular episode and see how real or how accurate the actors in this particular episode portrayed this particular spinal case. What's up, everyone? This is Dr. Webb here. Thank you guys for watching this video. Make sure you subscribe. New videos coming every week. You don't want to miss them. We're going to get started.
Oh, man, you beat me again.
No, man, you totally threw that. Okay, I'm on way too many payments for you to be losing to me. Hey, Dr. Lou.
Jonah, these are your surgeons, Doctors Shepard and Lincoln.
Hey. This is my brother Brady. You know, I would have left him at home, but he's my ride.
Jonah Mays, 18. He was diagnosed with progressive kyphoscoliosis at age 6. He's had multiple posterior spine fusions with instrumentation from T4 to L5 to correct the curvature.
Yeah, it's pretty much my entire spinal cord.
So basically what he said the patient has is progressive kyphoscoliosis, which is an abnormal curvature in your spine. If you look at the patient or someone from their side and they're bending forward, that's the kyphosis. And then you look at it from either the front or the back, that's considered the scoliosis. This patient, they stated, had multiple procedures in the past. He's had multiple surgeries. Usually after a surgery, you get a correction with, metal rods or screws. In his case, you try to do surgeries that do not fuse the spine as their patient's still growing, especially when he's only 6 years old and first got diagnosed with this. So him having multiple surgeries for patients in spine surgery can be common, but I just thought that was a little bit excessive, the number of surgeries he's had. There's something obviously that's going on.
I've had 15 surgeries in 12 years.
Some due to growth, some due to the condition's progression.
Yeah, the metal rods bust right through his skin. Can we take a look?
You're in good hands, Jonah. I'll leave you to it.
Looks like the degree of angulation has pushed the hardware off the bolts.
But you can fix that though, right?
Dr. Lincoln and I will remove the rods. We'll insert a nylon tether, which will stabilize your spine. It'll allow room for growth, which means fewer surgeries in the future.
Good. Because, I've got big plans.
So he has a pretty large scar on his back, which is pretty common. A lot of procedures in spine, the patient will get a good-sized scar. We have to expose a large portion of the spine. They're basically stating that his rods have poked through his skin. That can happen if the patient has progression of their scoliosis, and the goal is to correct the scoliosis with the first surgery so you don't have to go back for any additional surgeries. But if the patient has progression, they have a long construct, which means lots of rods and screws, and then they tip over the top portion of their spine. Theoretically, it can happen, but it's very unlikely that, some rods can poke through the skin due to progression. They can poke through the skin when the patient has an infection, and then the rods kind of appear through the skin, and that's more common.
I'm moving to California. I just got accepted to UC Berkeley. Go Bears.
Congratulations.
One step at a time, bro.
You're worried. I get it. I mean, who would take you to physical therapy and make sure that you got to the doctors on time? Oh, yeah, that's right. That's what you've always done for me. But I won't need it as much, all right?
Okay. We've got your measurements.
We will be back to prep you for surgery after we compare them to the scans.
Looks like we can use a VATS to anchor the bolts at T3.
Just like we planned.
Should be done by 5.
So usually we meet with the patient as a consultation. We meet with them in office or in what we call clinic, or in the ER if it's a surgical emergency or a patient that went to the ER for a particular condition, and then we go discuss it, we review their images, and then go back with the patient to come up with a plan.
Okay, Jonah, pre-op time.
Are we leaving now?
Why, you winning?
Yeah, but also, Brady went to the cafeteria. He said he was gonna go get an apple, but guarantee he comes back with fries. And we have this thing about saying bye to each other ever since our parents died 6 years ago in a car accident. And yeah, it was as dramatic and tragic as your face is right now.
Sorry.
So pre-op time, which means you meet with the patient right before surgery. You explain everything else that, hey, this is what we're going to be doing in surgery. You explain all the risks, benefits, alternatives to the surgery. Make sure the patient understands what we're going to be doing. We actually mark the skin with a marker because there's been a lot of wrong site surgeries in the past. So for instance, we're operating on the patient's ankle, the right ankle. We need to let everyone know that in the operating room, we're working on the right ankle and not the left ankle. So usually I'll mark the right side of the ankle with my initials with a marker to let everyone know that this is the body part that we're going to be operating on.
I'm going to give you something to relax you, and Dr. Lincoln is going to mark you for surgery.
Cool.
What are you going to study at Cal?
Environmental science or literature or something I haven't heard of before. I'm not sure.
Renaissance man. Nice.
Yeah, well, knowing what you don't know is the first step to enlightenment.
You will fit right in at Berkeley.
So that's pretty uncommon that the surgeon is actually giving the patient some medication before surgery. It's usually the anesthesia team, the CRNA, or the anesthesiologist, or the nurse who gives the patient usually some Versed, which is a sedative to relax them and calm them before surgery. But pretty uncommon for the surgeon to actually do that. I've actually never gave a patient and actually pushed it into their IV before going back to surgery.
Got it, okay. Hold these for me.
Until next time, brother.
Until next time.
Here, and take that. You practice, because the next time I see you, I'm going to kick your butt for real.
Okay. Alright.
Signal looks good.
Good. Angle
That
looks
procedure
good.
is a procedure where you're using a screen as well as a camera, and you look inside the spine on the camera to do the procedure. If a patient's very young and they have a lot of growth remaining, you can do what's called anterior tethering, which means going in and putting some implants, some screws through the chest cavity into the spine, and then attaching a tether to allow for continued growth. This patient is a little bit older. I think doing an anterior tethering procedure on him is probably not very realistic. With him, he's had multiple surgeries. He has a long construct, which means lots of screws and rods, and he's failed his previous surgery, so he needs a revision surgery. Revision surgery could either mean going through the front of the belly or the chest and then going through the back. So we can approach the spine from the side, from the back, or through the front.
Angle looks good. So, any food allergies? Nancy will want to know.
Doesn't matter because I'm not going.
So this is the VATS procedure that they're talking about. They're using a computer system, we call it navigation, to make sure that we're putting the screws or the implants into the right position in the spine. And we can see this on the monitor, and this is pretty common. Sometimes we do what's called a two-stage procedure, where we're doing one portion of the procedure one day. It may take 4 or 5 hours, and then we bring the patient back a second day or later that week to do the second portion of that procedure. And that's pretty common if a patient has a large deformity or the surgery is going to take 14 to 15 hours. You can divide it up over days.
Please.
The begging is cute, don't get me wrong. And still, no. You shouldn't go either. Life's too short.
Life is too short for what it will turn into.
So you see that they're looking at the monitor here and making sure that the screws go into the correct position. They're going through the chest, thoracic cavity. So as you can see, they're putting in the screws through the front portion of the spine here, through the thoracic cavity. But this is usually a procedure for young patients, not a patient who has had multiple procedures and he looks like he's maybe 20 or 21. It's usually for younger patients who have a lot of growth remaining. Most boys grow into the age of 16 or so, and most girls grow to the age of around 14 or 15. So he's done growing.
Go. One dinner with Nancy, and I avoid months of family gossip and drama. They already think I'm a train wreck.
Well, they're wrong.
Have you met me? Amelia Shepherd never told my family I got divorced. Ready to attach the tether?
So they don't get you. And what, they're mad because you and Owen eloped?
We didn't
It's
elope.
pretty
We had
common
a
for
wedding.
surgeons to just have conversations during surgery. We talk about sports, we talk about what happened over the weekend, any current events while we're operating. It allows for, great discussion, and it's a lot of fun to communicate and talk to your co-surgeons.
He's bending by the minute.
He's exaggerating. I'm fine. I'll be okay.
Jonah, we took a look at your scans and the tether
Please don't
just
say
isn't.
it.
Your lungs are compressed. We're gonna have to replace the rods so you can breathe.
But I have.
So this is very unlikely where a patient has a large deformity of their back or their spine and they're actually bending by the minute. I've actually never seen that. I don't think it's possible. They can develop deformity and progression of their spine over time, over months, but not over a couple minutes where a patient's having this much pain.
I have plans. What if we tighten the tether?
That's not how it works. I'm sorry.
Rods don't work. Okay, I'll need new ones again by the end of the year.
Tether didn't even last for a day.
And it's pretty unlikely that the surgeon can pick up and state that the lungs are being compressed by his spine. We usually do that with pulmonary function tests where the patient breathes in through a tube and you can get a lot of different parameters and lets you know how much of the patient's lung volume is reserved or how much lung volume they have remaining. But just listening through a stethoscope, you really can't tell that the lungs are being compressed from the spine.
What if?
Jonah, they said there's no other way, okay?
There's always another way. That's what you said when Mom and Dad died. I was scared because of how many people want to adopt somebody with my condition, and you said that you'd find a way, and you did. You quit law school so you could take care of me.
You can still have big plans, okay? Take classes here at
That's
community
not what I
college.
want. Ask me something else.
A vertebral column resection.
What's that?
Dr.
Wow,
Shepherd.
that's pretty aggressive. Going straight
would
to
remove
a
the vertebrae
VCR
causing
or
the
a
curve.
vertebral column resection. And this is a really kind of morbid procedure. It's done, but for patients who have really large deformities of their spine. Basically, you're removing a whole vertebrae and you're correcting that particular deformity. It has a huge complication rate. You can get paralysis, you can injure the spinal cord, different structures around that area, but usually reserved for patients who have large deformities, possibly his case, but I haven't seen his particular x-rays or any images, so I can't tell how large his deformity is or how big his correction is that needs to be corrected.
What's that?
Dr. Shepherd.
We would remove the vertebrae causing the curvature and replace it with a titanium cage that would protect your spinal cord.
It's a very risky, very complex surgery with many potential complications. Could result in
Do a
paralysis, even
VCR of the
death.
vertebrae or that particular block of bone that's in your back, you're basically taking it out. So you have to replace it with something. And you can replace it with, like she said, a cage. Sometimes it can be titanium or sometimes it can be plastic. Just depends on the surgeon's preference as well as the patient's characteristics.
Paralysis, even death.
But if it works,
It would permanently correct the deformity.
you can do it now.
I don't recommend.
Yes. It is risky.
That's pretty uncommon that the surgeons are disagreeing with each other right in front of the patient right there. Usually, if we have some disagreement or we don't agree on one particular thing or route to take, we usually go outside or go into another room or go into the doctor's lounge to discuss that patient's condition.
But if you decide that it's what you want, we could do it.
I want it.
No way.
Look, man, you had everything. You had law school, tons of friends, an awesome girlfriend. You were even captain of that weird ultimate frisbee team.
Hey, well, we were league champions.
You gave up everything. Now you have hospital food and waiting rooms.
I like the fries here.
You're the world's best brother. Okay, you're my personal hero. But I'm 18. I want the surgery and I'm gonna do it no matter what. I'd rather have you on my side.
I can't lose you too.
You're not gonna lose me. This isn't the part where I die. This is the part where I'm brave and it pays off. Look at her. Look at her eyes. She says she can do it.
Till next time, brother.
Until next time.
He asked about his options.
Paralyze him. A woman just became quadriplegic on our table.
That was out of our control.
Exactly. There are no guarantees. Our patient has to come first.
I am putting him first. This is what he wants.
This is what you want because you've still...
Usually right before surgery, we go in and we scrub our hands, we wash them at a sink that's pretty similar to this. And then during this time, I'm usually going through the steps of the surgery in my head. I am trying to think of what can go wrong, what things I need to look out for, as well as sometimes I even say a short prayer.
Got something to prove.
Do I need to find someone else to do this with me? Because I will.
Amelia, I'm saying it's been a rough night. I'm saying your sister just treated you like a teenager. You questioned your surgical skills.
I can't care what they think.
You think you don't care? I just spent the night pretending I was Owen.
This is not about them. I cannot let them define me. If I did, I would still be the messed up baby of the family, the person that I revert to.
She's pretty confident. I like that about her.
I am with them, and that is not who I am.
I know that.
So there's a picture in the left-hand corner there of his, appears to be his x-ray or CT scan, and you can see his neck is kind of leaning forward. Usually after a long construct or a long surgery where you have lots of hardware and screws, the patients can develop what's called proximal junctional kyphosis, which is basically leaning forward at the proximal or top aspect of their construct. This can be symptomatic, and if it is, requires revision surgery. You can see at the inferior portion of his spine also, there's possibly some screws that may be coming out and may be loose, but looks like he has hardware and rods all the way up from his thoracic spine and then possibly going down to his sacrum. So he's had a lot of procedures.
Get me the titanium cage.
Careful of distraction on the cord.
So that's a real small implant that they're putting in. If they are removing a whole vertebral body, the implant's a little bit bigger than that, but these days some implants can expand, which means they're small before you put them in, and then you can turn it or crank it to enlarge the implant. Like we discussed before, this procedure has a high complication rate, and if you damage anything in the procedure, the patient's spinal cord is exposed and they can become paralyzed. So very high risk type surgery.
Dr. Shepard. Shh.
Please.
So this other person that's in the operating room looking at the monitor, the little squiggly lines that are moving, this is usually a person in surgery. It's called a neuromonitoring tech who hooks the patient up to wires before surgery, and they can monitor any changes in their motor activity or sensory activity and will tell the surgeon, hey, this patient's right side of their spine, you're cranking too hard or you're using your retractor too much. The neuromonitoring tech will communicate with the anesthesiologist as well as the surgeon to come up with a plan in terms of what to do next. Usually we check with the anesthesiologist and make sure that the paralyzing agents that they have the patient on during surgery are either turned off or turned on. And then we assess to see what we just did. If we made a large correction, we usually can reverse that, take the rods out or take the screws out and see if the neuromonitoring has improved.
Signal's back.
Yeah. He is not paralyzed.
I've never heard of anyone in surgery saying the patient's paralyzed. We usually wait until after surgery and make them wiggle their toes or move their legs. And if they can't do that, there's possibly something happening in surgery. But saying the patient's paralyzed based off of what you see in surgery is pretty uncommon.
I wanna break these bones till they're better. I wanna break them right and feel alive. You were wrong, you were wrong, you were wrong. My healing needed more than time. When I see fragile things, helpless things, broken things, I see the familiar. I was little, I was weak, I was perfect too. Now I'm a broken mirror, but I can't let you see all that I had to lose, all I've lost in the fight to protect it.
So they ended up doing a VCR, or vertebral column resection, for a patient with a large deformity of their spine. This is a procedure that can correct that deformity, along with other steps of the procedure that need to be done. But yeah, fairly accurate, but there was a lot of things in this particular episode that was not very accurate. This is Dr. Webb. Thank you for watching this video. Make sure you subscribe. New videos coming every week. You don't want to miss them. We'll see you next time.